Welcome back to one of our uh, uh, broadcasts that we do every few weeks. And we are again honored and thanks to Dr. Wood for joining us today to bring up to date about this COVID-19 related pandemic, which is taking a tremendous toll in all our lives, not just locally, not just in our states, but all over the country and all over the world. So we do have a list of some questions that we got from the audience, and we'll try to cover a lot of material today. So let's start just with a few simple statistics, which is sort of mind-boggling, and we're getting numb to these numbers. To this day, today, we have 19.1 million people in the world affected with this COVID-19 virus and 715,000 deaths. USA, which is less than 5% of the population of the world, has the sad and dubious distinction of having 4.9 million cases with 160,000 deaths. And if the trajectory goes the way it is, it's expected that we might go up to 300 plus thousand by the end of the year, which is sort of scary. West Virginia and Ohio has not done too bad. West Virginia has only 7,433 cases with 127 deaths, and Ohio has 97,000 cases with 3,000 deaths. Just for comparison, which is very interesting to me, Korea has a population of 51 million. That means we are 328 million, six times more. They have had only 14,000 deaths and only 303 deaths, 303, and we are five times their size and we have 50 times their death rate. It's scary. So we're going to try to cover some stuff as to why there's such distinction, but also we're going to talk about some practical points. And we're going to start with some questions. And Dr. Wood, why don't you say a few words to begin with? Then I have the list of the questions that we have, and many of them are duplicates, but we'll try to cover many things. So, Dr. Woods, thanks for again taking the time. I know you are much busier than I am, and I'm very busy. And thanks for taking the time to do it. So, please go ahead. Let's start.
Yeah, you're very welcome. I'm honored to be here and share the knowledge I have, certainly with coronavirus going on around us. As you said, we still have a lot of cases that we're seeing. We're certainly not over the hump as far as this illness goes. It's not seeming to let up in the very near future. So I think it's ever more important now to continue discussing with our viewers, what they can do to protect themselves, protect the society around us, so that we can fare more favorable than the trends we're currently setting. Some countries have done better, some have done worse. But certainly there are strategies that we can do to certainly help, keep our citizens safe, keep our families safe, keep ourselves safe. So hopefully we can help answer some of those questions with the viewers to try to keep everybody on the safe side of this while we, work towards a vaccine, a cure, better therapeutics, so that in the end, at the end of the pandemic, we're sitting in a better position with hopefully less mortality, less affected, whether that's infected or severely, affected by the disease.
So, let's start with some of the questions. I have a long list of things that you and I want to talk about. Um, a lot of it will be concerning the testing, mask, the rate of being positive in a community, how many people are positive in a community, what's the role of these tests that we're doing and how we're doing, and the schools and the restaurants and the vaccinations and the new treatments and all that. Let's cover what we can. These are some of the questions. Let's start with that.
Okay.
Um, it's been said that drug therapies have been successful to fight or prevent the virus. Can you please give an update?
Yeah.
So go ahead.
So our most effective drug right now is one single antiviral agent called remdesivir. It's approved through the FDA for emergency use. It was sort of rushed through because of the unexpected nature of this illness. It's been very effective so far, but much like a lot of our antiviral medications for our other respiratory viruses like influenza, is it's most effective in the right settings, started early in the right patient. We have very, very limited supplies of the drug. And so what we can't afford to do is to utilize it on some folks that are having very minor disease, asymptomatic disease, that are going to have full recoveries, to have really no chance of having mortality or severe disease. because it's probably not going to affect the outcome in those patients. The same is true when we have the opposite end of the spectrum, where we have patients that are multi-system organ failure, have a mortality rate of 90 or so plus percent. The drug's probably not going to make a benefit to that person. So we really have to look for that middle ground to see who's the appropriate candidate for the drug, because we have very, very limited supplies. Many hospitals have no supply. And so it's not as luxurious as some of our antibiotics, where our pharmacies can make an order, purchase it from the suppliers, and get hundreds or thousands of doses in. We don't have that luxury with this medication because of how quickly it was developed. And actually, most of the allocations have been given from the drug company through the state and the government and allocated to the hospitals that are seeing the cases. So based on the percentage of cases in Ohio, for example, hospitals were allocated certain amounts of the drug. That said, the other therapeutics that were once tried still have staggering data across the board. Hydroxychloroquine is the one that hits the media most of the time, or Plaquenil, which is more commonly used for things like rheumatoid arthritis or lupus. In the early days, we utilized that drug, but in the more recent clinical trials, it was suggested that there's no benefit from it, and we don't have good data to support its use. And DEAs have actually come out with recommendations against it. In the state of Ohio, for example, everybody prescribing that medication has to put the diagnosis now on the order or script, and they're instructed at the pharmacy level to refuse the script for coronavirus because of that lack of safety and efficacy data. And so now the prescribers risk having a DEA sanction if they're prescribing it for this virus. I just had a discussion yesterday with a pulmonologist because he had a patient in his office reading some of the information in the media, and was insistent that they needed this prescribed for them because they were confirmed positive. And so now it risks the prescriber's license if they were to prescribe it in some states, because it's not proven to be effective. So I certainly caution any prescribers utilizing it outside of clinical trial settings, where we are trying to evaluate it thoroughly to see if it has efficacy. But the only option right now that has been proven to be successful is remdesivir. I can tell you from personal experience, we've had a handful of cases at Trinity Medical Center where we have utilized the drug in. All of them have been very quickly recovered, discharged home on no oxygen within a matter of a few days. So it's been very miraculous in that regard, but obviously very, very limited supply that we have on hand.
Okay, let's say a few words about, well, let me just tell you an interesting story about the hydroxychloroquine. Unfortunately, in our United States, from the top of the government people, and there was not too long ago a lady from southern part of the country who was advocating the use of hydroxychloroquine and no need for masks, and she's cured 350 people without these two medicines, with hydroxychloroquine. That's nonsense, absolute nonsense. In Brazil, the president of Brazil himself was taking hydroxychloroquine and he became positive. And so I think we should let this rest. That Dr. Fauci and the team is not advocating the use of hydroxychloroquine. It should not be encouraged. Dexamethasone, the steroid, just to say a quick few words as to that is another medicine we had for 40, 50 years, but I've used it for many other purposes. That has been found to be dexamethasone.
Absolutely. So in patients that require oxygen supplementation or intubation with mechanical, ventilatory support, in those particular individuals, the dexamethasone or similar steroid equivalents has shown decreases in mortality. And so, we speculate that it's decreasing the SIRS response or inflammation response, which is where a lot of these folks get into trouble as far as ARDS and, inflammatory airway disease, to where it's shutting down the immune response that's causing the overwhelming respiratory failure. And so, the current recommendations are somebody that is on oxygen therapy or intubated with confirmed or highly suspected COVID to have, steroids on board at the equivalent of around dexamethasone 6 milligrams for anywhere up to about 10 days. So it certainly has shown to be favorable, but it's not an antiviral, it's an anti-inflammatory that's decreasing mortality for these folks.
Okay, let's talk a very important issue about masks. Let's just put a little background to it. The studies show that had we instituted using masks even earlier than we have, and even though half the people are not using it, and now the latest number tells us that unless we do something such as using a mask, the number of fatalities by the end of the year is going to be 330,000. And they're saying categorically the proper use of the proper mask can reduce the death by 70 to 75,000 people by using a simple modality such as mask. And yet, in this country, more than many other countries in the world, we are fighting over it. We are politicizing it. We are making it like it's our right not to wear it and all that. That's nonsense. I think if 95% of us use the mask effectively for the next 4 months to 6 months, till we flatten the curve, till we do everything right, we could reduce 70,000 deaths. That's unbelievable number. So let's have you tell us, because you have a lot of experience about the mask and their importance.
Yeah, you're absolutely right. So the mask really has twofold. If we're healthcare workers in the care sector taking care of these patients, it will protect us from exposure, and acquiring or getting the virus if used appropriately. But more importantly, if the folks that have the illness that don't know it yet and are shedding the virus are out in public, they're at the grocery store, they're at a community event, and they're shedding the virus with a mask on, that mask will protect everyone around them. So that's where it really comes into play, as everything you mentioned, flattening the curve and decreasing the transmission, decreasing the deaths. Less people infected equals less people dying from the disease. And so if you have one person that goes to a church function or a wedding and there's 200 people there and they don't realize that they're going to have the illness, but they're shedding virus, we're going to have several people come in close contact with them and get the disease if they do not have a mask on. But if we have everybody wearing the mask, you have the protection that even if you're shedding the virus asymptomatically and doing things appropriately with a mask, washing hands, it does have the ability to contain that from spreading in that sort of environment. So instead of an entire, church or pep rally fundraiser getting infected with, 70 or 100 cases, you would have one person that went infected may still get their symptoms in a day or two, but only one would be infected. And so that's how you can see the exponential growth, because if 70 people get infected at a fundraiser or event like that, those 70 then go back to their workplaces. And if you work in a setting with 10 or 20 other people, more get exposed. And in the course of their lives, more and more people get exposed exponentially. So it's really an exponential or logarithmic growth that we're preventing by something as simple as wearing a mask. I do want to mention, though, wearing a mask does not make you invincible or bulletproof. I see a lot of people nowadays at the grocery store, at the gas station, and out in public wearing their mask. And they're either A, not wearing it appropriately with the mouth exposed, the nose exposed, they're wearing it on their chin, or the mask is doing no good. It truly has to cover the nose and the mouth to be effective. And number two, we have to wash hands diligently with any of the products like Purell, the alcohol sanitizers. Even when there's not soap and water, they're very effective. But I see a lot of people with the mask on, touching everything, putting the mask down and scratching their nose. Everything you've touched with your hands is now in direct contact to your nose. The mask was no use for that person. And so it's very important that we still have to have hand washing. So I can tell you myself, I have one on every desk. I have one in my office, at every exam room, out at the common station. I have one in my car. I have one of these everywhere. My kids have one on their backpack if they're going out. And so every time that you're touching things, you should be utilizing those products, irregardless if you're wearing a mask or not. At some point, you're going to take your mask off or not realize that you may be touching your face. If your hands are contaminated, that then puts the contamination directly into your mouth or nose. And so it's incredibly important that we have to do both.
Yeah, absolutely. And also, by the way, some people who took this disinfected usage too far, when the president mentioned that we can ingest it, inject it, and all that, they've reported 12 deaths for people who were drinking this stuff, trying to undo the damage. This is strange story, but that's true. Now let's take just a few words. We know about the most powerful way the virus spreads is through the aerosol, the breath, the talk. But the contact surfaces are not as big a deal as the person to person by breathing, talking, singing, being together.
Yeah.
Eyes also have been brought into the issue that maybe if people have high viral load on their face, but face is protected, but the eyes are not, there's an indirect wave from the tear ducts. It can go down the nose and the throat, the lungs. Yes, it can, but uncommon. So we don't have to be wearing goggles except in medical personnel who are hospital people, hospital employees, or people who are dealing with close contact with high volume virus load. So I think most of us don't need to be protecting our eyes, but face and mouth and nose are very powerful. Now let's talk about very important issue, and that is the test that we are doing today, and it's taken a week to 10 days. That's practically useless. The test we need to diagnose COVID 19 right now, if you or I wanted to do it, we need the results in a few minutes, few hours, no more than 48 hours. But any company which has taken more than 48 hours, the test is practically useless. So we are trying to find a way. I mean, let's say a few more words about it as to it's very difficult now in your hospital. You do the test where you get the results in a few hours. I just had to send a patient last night. Blood. It was the test for the COVID-19. We may not get the results till Monday. Till then, this patient in the intensive care unit isolated, and the test may come out to be negative. So
Yep.
let's say a lot more about the testing, where we are, which kind of test, the PCR, the antigen, and the antibody, different kinds. Let's say a few words about that. All yours,
Yeah,
please.
so the PCR test is the gold standard right now, which is the nasopharyngeal swab, the Q-tip that goes into the nose to the pharynx, swirled around, and we look for the actual viral PCR particles for the DNA. So that is the best test. And even that said, the sensitivity has been subjected to somewhere in that 70 to 90% range, which means in as much as 30%, we could even miss illness with the best test we have available. So the test, when it's sent to reference labs, oftentimes has to be shipped there with a courier. By the time they process it, give the answer, it takes several days. We're fortunate enough that we have in-house testing, so our actual lab in the hospital can do the test. They're running the machine almost around the clock, trying to get as many batches a day as they can do. It's a lot of hands-on time for the machine, so a tech is constantly putting reagents into dwells and samples and processing it. It's not as simple as an automated process where a computer or robot does the work and spits out the answer. So it's a lot of very tedious and technique that goes into that test. But as quick as a turnaround as to 4 or 5 hours, we've seen results on that, which is good when it's working. We're getting answers at the point of care as close as we can, but certainly not ideal because we have a very limited amount of tests we can do on that. Still, when we're sending some of our samples when the machines are down to the reference lab, it's taken us around 48 hours to get most of those back. And those are getting couriered to Pittsburgh, Granite Quest Labs, and the answers, faxed or electronically delivered backwards to us. And so the antibody tests still have no place as far as diagnosis of this illness. Remember, that's a blood test to look for an antibody response. Our body takes on average 7 to 10 days to mount any type of an antibody. And so before you have a known antibody response, you may have completely been recovered from the disease or progressed all the way through the severe stages if that's the evolution it's going to take on that individual. It's also very less specific. So you could have had a positive infection 3 or 6 months ago and still have antibodies today. We can't distinguish that on an antibody test. So it really has less practical use in clinical practice managing a patient, as opposed to if you're doing surveillance studies, you're looking to see in a population who's exposed, the antibody test may have some role. So the antibody test for me as the clinician really doesn't have a purpose. It's all based on the PCR. Some places have come up with an antigen-derived test where it's the nasopharyngeal swab, and rather than doing a PCR, they'll do nucleic acid looking for the antigens. Its sensitivity is a little bit less than the PCR. I believe FDA still requires it to be confirmed by a positive PCR. So if you have a positive antigen, they would have to reflex it to a PCR to confirm it, although a negative one should have some predictive value to exclude the disease. We don't have access to an antigen test. I'm not sure where may be offering that, but it's probably the newest of the tests that has come out. But much similar to our influenza virus with the antigen, is the sensitivity is just not what a PCR test can offer. So the PCR really is still the gold standard as far as testing goes.
So the few things about the testing is, one, in some countries of the world, they are getting faster to get the turnaround in a matter of few hours. Number two, the antigen test is about 85% sensitive. If it's positive, it's helpful. If it's negative, it may be false negative. So now it's hopeful in the next month, 2, 3, 4, instead of everybody trying to get this test done, which is delaying it even more, and making it useless by the time they get the results. We need to be selective who gets the test done. Now that's where I have to answer your question. The way the schools will open and the communities will open, it depends on what's called the high positivity rate in a community. Let's say in Ohio, Steubenville, Weirton, and our area, if we have high positive rate, if you do 100 patients and just do the 100 tests and you find 10 positive, that means we are in big trouble. We probably have a lot more people out there don't know it, they have the disease, they may be spreading it. So we need to bring down the high positive rate to less than 1% to be comfortable before we say, let's open this school in this district or this business in this area. Say a few more words about that, and then we can talk about it.
Yeah, absolutely. I get a lot of questions about that, and also, specific questions about, the cases in terms of what's going on in the community and the schools, opening and that sort of thing. So it's all interrelated. But we have to remember two things that you briefly touched on that I think we should elaborate on is, number one, the test is a single snapshot in time. So at the point when the swab is placed into the nose, that's when it's looking to see if the virus is there. So if that person was exposed and they're incubating the virus, meaning they have it, it's getting included into their pharyngeal cells. Our cells have to remanufacture the virus DNA or replicate it because viruses are not alive. That process takes on average 5 days, but as long as 14 days. So if somebody does not have active disease and they're shedding the virus, but they're about to in 24 hours or 2 days from now, the test can be and will be negative. So it's a single snapshot in time. So when somebody that's asymptomatic, we have to recognize looking for somebody asymptomatic but shedding the virus is very different than checking somebody with florid symptoms looking for the virus. And it's also interrelated in what you mentioned earlier is a lot of the tests that we're sending, if they're for asymptomatic folks for quote screening, if you will, is we create a bottleneck at the testing source at the machine. So if we want to screen, all 10,000 students that are going to come back to school in the primary school in the area, it would take 10,000 tests to do that. It would take us, an entire year on our machine to probably process 10,000 tests. So if we were relying on the send out lab to process those, and we have the equal person sent on the same day that's say in our ICU with multi-system organ failure, they're going to bottleneck at the machine that can only do so many samples at a time. So then we run the problem of the person that has, a benefit potentially from a drug like remdesivir that we have limited supply on, their results are getting delayed because we're processing tens of thousands of asymptomatic folks that maybe are returning to school or, some of the sports teams that are mandating this. And so it causes delay then on the patient care side. We don't have open access, unlimited amounts of testing for this disease because it is so new. And as a result of that, we really have to watch who is getting tested because it can create problems for the people that are critically ill and truly need the test as fast as we can get the answers back.
Well, we need about 5 million tests to be done a day to get ahead of the curve a little bit. And secondly, in that tone, what you just said, since the bottleneck is making things worse, well, say a few words about the pool testing. Let's say you said 1,000 kids go to a college. Instead of doing 1,000 tests, because they recommend that those colleges, when they go back, those kids need to be tested twice a week or once a week. Let's say we divide them up into 10 groups. So you only do 100 tests rather than the 1,000 tests. If those 100 tests, they're all negative, that group is safe, relatively safe, right?
Yes, but that's not pooled testing. So that's still, that's randomized testing, which can be helpful. But pooled testing would be if you have 100 kids that are, say, in a dorm, and you swab 100 kids, rather than putting all 100 on a separate sample in the machine, you would process them in batches. So you might do 25 in a batch all together with one set of reagents. If it's negative, you've ruled it out for 25. If it's positive, you would not know which of the 25 were positive. You would then have to separate out those 25 and run them individually. So what we know is instead of testing 100 people and having to use 100 times the reagents and supplies to do that, we can batch it in smaller groups, usually around 10. But if you could do 25 just to make round numbers, you would only use 1/4, the reagents that you would do processing them, compared to processing 100 samples, you might be doing 25 in a batch, you'd do 4 samples. So we can conserve on the products and supplies to do that. but it does decrease our sensitivity. It's similar to, if you're using a chemical or compound, we're diluting that compound. So if you're using soap, it's like adding water to the top of your empty soap bottle. Eventually, it's so diluted, the actual chemical or soap may not be effective. So if we dilute the samples too much, if we did
Right.
50 in a run, we wouldn't be able to ever detect it. It would always
Right.
be negative.
Right. Let's talk about schools. Some of the questions are: the CDC announced that it's best for the children to go back to school full time, face to face. What are your thoughts? If one child contracts COVID-19, do you feel it's necessary to shut the entire school down? And also, if you feel the school should be shut down, when do you feel it's safe for children to return to school? Third question, the same tone is: should the children wear a face shield or a mask? And should the children wear the mask at all times? So all those questions are about the children in school.
Yeah,
And by the way, before we go off the subject here, New York now has very low high positivity rate. They are trying to have other people not come to their state, and they're trying to open up more schools and all that. But some states have very high positive rate, 10%, 8%, 12%. So we really have to be aware of the fact that at any one time we need to know how many people in your community or my community have carrying this virus without even knowing it. So let's go back to the children's now. Tell us about your feeling, your young children, but going to school, and my grandchildren, and I'll tell you my experience the last few weeks.
very good. So, it's a very hard question to answer. And I certainly, we have viewers on probably all three states here between Pennsylvania, West Virginia, and Ohio. So, number one, always check with your state to see what is required. And so I know, for example, in Ohio, they just passed, I believe, last week that the children returning to school, K through 12, will be required to wear a mask. Pennsylvania's had that in place for a long time, so we've been, much a longer lead-in of preparation for that. But it will be required with some, exceptions to that, with medical exemption. Obviously, eating lunch isn't prohibited. So in the state of Pennsylvania, for example, if a child is seated at their desk and they're at least 6 feet from everybody else in the classroom, so the teacher, the students, they can remove their mask and place it on the desk, and be mask free, if you will. But if the teacher is passing out assignments, collecting assignments, and doing any type of, instruction, they would be expected to place the mask back on. Same, holds with the teachers. They're expected to have their mask on when they're doing these instructions. And so, as we mentioned earlier, the masks are very effective to contain this from spreading. Yes, I think they do have a place right now with putting, kids in close corridors. I believe most of the schools are trying to spread out their physical distance between the desks and the students so that there is that 6 feet. But also they're looking at how they can minimize the travel, if you will, of students among the school. So in a lot of schools where they may transfer to an art class or a music class, instead of going and traveling about the school, they may stay locally and let the teachers change. So instead of the math class being down the hall, the math teacher will come into the same classroom that reading was taught in. And so the teachers will rotate. Obviously, that's less practical for some of the higher level of grades in high school and such, to where the kids are not always the same group at each of the classes. So very challenging for the teachers, but certainly they're working very hard to try to do what's best to try to prevent things. But the mask has a very large play in that. So as far as my own kids, I do plan to send them and have masks on them. We're stocking up as far as our Purell products and the like, so that they have some to put on their desk. Our schools are asking for donations, so we're trying to donate some of those products. If you have the ability to, I encourage folks and parents to do that, so that they can wipe down desks. So they're planning to, wipe down the desk 2 to 3 times a day, especially before meals. They're going to eat at their desk instead of going down to the cafeteria. So a lot of things are going to be changed for these kids in our schools, that the school boards have placed a lot of attention on trying to minimize, the spread of this. So I certainly think that there's, opportunity that we can prevent things, but it will pose challenges with the younger children because, as any parent will tell you, somebody that's 3 or 4 years of age, the governors have suggested down to 2 should be able to wear a mask. I don't know a single 2 or 3-year-old that's going to safely or effectively wear a mask. I think it's impractical. I think they have the ability to for very small, jaunts and durations, but not enough to probably be effective. So the younger the child is, I think it gets very, very difficult to enforce.
Obviously, it helps be individualized in each location, each locality, the each area, because it's going to be Now, I don't know if some of you saw it or not. Yesterday only, a school in Dallas, Georgia, a 15 years old young man took this picture and posted it. I don't know if you can see it, but you might have seen it maybe. And he was fired from the school because of his ability to take this picture when people are not wearing a mask, all the students down the hallway. And that's the kind of situation we are dealing with where you can't have one rule affects all, but masks are mandatory as far as I'm concerned, every place, unless there is a reason not to wear. And also, as you know, in Sturgis, South Dakota, there'd be 250,000 motorcyclists gathering together, and mask is not required. That seems strange to me, but anyway, this is the kind of situation you're fighting where half of us, for some reason, do not believe that masks are important. I think it's crucial that we do that. Let's talk about um, uh, flu season coming up. That's going to compound our problem where we're going to have patients with flu, patients with COVID, with both. That's probably going to put a lot more burden. And one of the questions somebody had was, how are your local hospitals handling it? And what has been the most difficult challenges for you?
Yeah, so I agree. Flu is going to be very difficult to ascertain, symptomatology as far as who is presenting with flu or who's presenting with COVID. For the most part, they're both respiratory viruses. They're both contagious illnesses, so we're going to have to isolate to protect staff and other patients accordingly. But the therapeutics are going to be very, very differently in those two individuals. Certainly, we'll have to work on diagnostics, and hopefully by that point we'll have better testing for COVID because we have pretty decent testing in place for flu. But certainly we'll have to work on that. There's some speculation as to how flu season will actually take place this year. Typically in our part of the world, flu season starts come, late October, November. We start seeing some early cases. Typically we have a peak somewhere between, January, February, or March, and then cases die off. But what we don't know is with COVID happening and everybody's practicing social distancing, the masks that are being used, how will that change the duration and the typical features we expect from flu season? Will we have a slightly less virulent season this year? Will we have less cases or spread? That's all speculation. If people really are wearing their masks and socially distancing, we may not see the volume of flu cases we're used to seeing, which would be a good thing. But as time goes on with governor's orders and the state of emergency that was declared, we're learning that as time goes on, less and less people are listening to the criteria they're expected to do and listening to the recommendations. And so come October, November, January, when flu season is here, if folks are not doing that, we're not going to see anything different than our typical flu season. So the jury's still out what will happen, I think, with flu season. But if we are wearing masks and doing these things to prevent against COVID, we're accidentally preventing flu spread as well.
Let's talk about two other things that we talked about briefly before. One is you have a few weeks ago very nicely explained how you use the UV light in our hospital environment. But I read something very interesting. Maybe we can talk about it next week. Something called FAR, FAR UV light. That's something very new that I am very interested in learning as to this particular type of modality that they're working on is going to help us decontaminate our surfaces and our bodies without damaging the skin and all that. So something called far UV light is an interesting new concept being looked into to use it very widely, where we can have the light bulb put something which will emit that UV light, which will not penetrate the deeper layers of your skin and only be the outer layer which is protected by other tissue. So I think that's something we'll talk about that the next week or two. I think I sent you the link to that to read, but you probably haven't had time to look at that yet. So now let's talk about very important issue, very important. Where are we with the vaccines today? And when we got them, how will we handle? And then I'll give you the opinion from one of the brilliant scientists about this issue. Go ahead, please tell us all you know so far till today. Where are we with vaccines?
So we have several vaccines that are in late phases of clinical trials, look very promising on animal studies. Several are in the phases of human studies, enrolling individuals. I believe you can go online and still volunteer for some of these. And so they're testing not only safety, but efficacy as well to see, if it's effective enough to meet the endpoints and get FDA approval. As of right now, none have reached the endpoint with FDA approval, but there's at least 6 vaccines that are very promising from some lead manufacturers that have been making vaccines for us for many, many years, as well as a couple that are newer, companies that are pioneering into that sector. They're very promising. What we don't know so far is the details on how to expect the vaccine to be. We think of some vaccines that are once and done, that once you've completed a series, you're immune or protected for life, like a hepatitis B, hepatitis A. Could it be something like influenza, where a similar type of vaccine would be expected to have a shorter term immunity, maybe last for 6 months, a year? That's all unanswered questions right now. We do know some evidence that those that recover from COVID and have antibodies, that you're probably protected by those antibodies from getting the illness for at least 3 months. And so we don't know the level of quantified antibodies. So that's a question I get asked by some of the providers. Is there an antibody we can measure and say if that person's immune? We don't know that yet. But those that have contracted the disease for probably 3 months have levels of protection to where they would not get it if they took care of a family member, say a month later after they had it. They probably would not acquire it again. So they're trying to factor some of the knowledge we have with the antibodies in with the vaccine development, because ultimately the vaccine is boosting our antibody response, our humoral immunity, to where we have memory immunity to protect us if our body becomes exposed after inoculation with the vaccine strain. And so we just don't have a lot of data yet to suggest where that's going to pan out, but they are very hopeful that come this upcoming fall, and certainly by the first of the year, has been the deadline they're all striving to achieve.
It's thought that very likely the last month of this year or the first 2-3 months of next year, we should have some effective vaccine approved. By that time, it'll be the FDA and the officials are trying to tell us that no political pressure is going to influence their release of the vaccine when it's released, when it's approved after safety and all the stages that has gone through. Now, what percentage of people are likely to get it or receive it once? Now, right now, there's a lot of enthusiasm about patients volunteering to find out more if they want to be part of the study. But once we get it, what percentage of public we need to make sure that it is effective for the whole in bringing the herd immunity and long-term benefit?
Yeah, so some of the studies I've seen online with surveys and whatnot is a lot of folks are either indifferent or decided they would not accept the coronavirus vaccine. And so the numbers that I was seeing was somewhere in the like 10 to 20% range that are confirming they would accept it if it was FDA approved and available today. To me, that's a shocking number. I would have expected higher. But when you go back and look at our historical data with a lot of our vaccines, we don't have a lot of adoption. And so influenza, for example, hospitals and healthcare facilities are regulated by Joint Commission and others to achieve certain thresholds of vaccine. We promote it. We know that it's a very good, effective way of preventing influenza. But yet, outside of that, in other occupations, the vaccination rates are abysmal, usually single percentages for influenza. And so I think it's hard stretch to suggest that we would have coronavirus ever vaccinate somewhere like 70% of the U.S. population, unless it is some levels mandated for things. I don't think that's probably practical on a voluntary basis. To truly get us herd immunity, the higher amount, the better. We'd probably have to get at least 40 or some percent to give us any amount of measurable herd immunity from it. So if we were to only vaccinate 10% of the population, in the country, it probably would not protect us from the social environment. If we were to vaccinate, say, 90% of our hospital workers, it would certainly give us herd immunity at the hospital sector from patients and from coworker to coworker, where we do see other disease transmission. So you have to look at the local sector and then the more broader spectrum as to who that population that could develop herd immunity.
Also, let's say a few words, because it's in the limelight recently a little bit, and even though we don't talk about it, the toll this pandemic has taken on patients' mental health for many reasons, whether financial or being cooped in their places and isolated, is taking a toll of causing a certain degree of mild subtle depression, major depression, or even high rate of suicide. And as recently as Mrs. Obama came out and said that she's going through this some degree of depression from this, and a few other the world now the swimmer Mark Spitz. So there is a tremendous unspoken uh, dialogue that we have. We're out in the public, people who are starving for jobs and trying to balance their family life, whether the children go to school or they lose the job, they don't have food for tomorrow, and they are down to the last penny in their bank, or if they have any left at all. Uh, this is going to be another gigantic toll on our society unless we can find a solution both from the politicians and as communities at large to help each other out in these difficult times. It's coming out ahead. Um, Now, one of the most brilliant scientists who recently, again, and 10 years ago, he warned us, Dr. Larry Brilliant, and he says that this pandemic virus is different than the ones we've had before in a way, that this affects all our organs from nose to toes. It is like a very um, fast approaching high incidence of morbidity and mortality, and we are in for big trouble unless we not just as society locally work together, but all the countries of the world somehow. Once we find the right vaccine, whatever we find, we need to share with each other the knowledge and distribute it where it's needed, regardless of who is who and who is from where. That's going to be a pretty challenging task because they're saying even when we have the vaccine, just the fact we'll get it into where it's needed is going to be a monumental task. So we have a lot of difficult times ahead. So till then, I think you and I will continue to say, number one, continue to do what we're doing, hand washing frequently, 6 feet distance or more when feasible, and face mask, face mask, face mask, face mask all the time. Now, other things that we need to do, what else can we do? Go still enjoy the outdoors a little bit. Vacations to some degree are safe if you pick the right way of doing it. Travel by car is somewhat safer than travel by planes, I would think, to some degree, maybe not. And what else? What else are some of the things that you and I can? I'm not ready to go to a restaurant inside yet. I did one time the last 6 weeks, and I think I felt uncomfortable afterwards. Traveling on the highways, I think, is safer if you do all the things we talked about.
Yeah.
What has been your stressful working this 7 days a week in this field? And you and I actually are very fortunate that we're really not suffering any personal difficulties on a daily basis. We've had some more positive patients. This area, you have a lot more this side. But people who are confronted in ICU and seeing death as they see up close, it takes a tremendous toll on the medical personnel and all people involved that care of this. So it's a pretty difficult. I think we have many states, at least 9 states, which still going. The numbers are going up, and plus when the numbers are going up, the people are going to die 2 weeks later. So we probably have some of the highest mortality the last 1 week, 1,000 to 1,200 patients a day dying. When I think we need to, by doing what you said, face mask and everything else, if we can impact the death rate by 60, 70,000 people in 4 months, that's mind boggling. And yet I find it hard when you see people who are fighting each other. Some lady broke somebody's leg the other day in a store because she didn't want to wear a mask that she pushed her. So I think we need to get over that stage. Don't listen to the politicians, listen to the scientists, Dr. Fauci, and like you and our each community, and follow the instructions. What else would you like us to take home some lessons from for the last?
I think you summarized it up very good. Certainly the most unexpected, I guess, part of a pandemic like this is exactly what you mentioned with the psychosocial nature and the emotional or mental well-being. Especially us as physicians, we're prepared to take care of the patient's, symptoms, their medical illnesses, whatever it happens as far as the body goes, but we're not always as prepared for the mind in the aftermath of that, whether that's the patients, the people taking care of the patients, the families, and not only those that are infected, but those that are affected just by what we've had to do differently with the quarantines, with the lack of travel, lack of visiting with family and friends like we would normally do. We take a lot of things for granted, and it's not until you have those things taken away that you realize some of those benefits. And so I think that's where a lot of us, currently in the United States are struggling right now, is we've done without things that we've never thought we had to do without, whether that's something as simple as going out to a restaurant and having a meal, or, visiting neighbors, friends, family, where typically you would, walk across the street and maybe have get together with 4 or 5 neighbors and kids. Now that's just not practical. And so we've really had to shelter ourselves and change our lives for the, good of our societies, but to flatten this curve. I think from a personal perspective, that's been very difficult. With my kids and families and stuff, we're used to going out and having, time at the pool and time to go here, on a summer vacation, and putting all of those plans on hold. Certainly over time, starts to build up to where you don't have that chance to just relax, unwind, decrease emotions, for our own, mental well-being. So I think that's certainly been very challenging, as a personal level goes, that we've all been struggling to deal with. Those that have been even as unfortunate to have had jobs that are closed or lost. A lot of our factories were shut down for several months. I have a couple of patients that were certainly affected by that, to where they had no income for 2 or 3 months. Some of them will qualify for disability or unemployment to a degree, but usually that never suffices to what their income was generating if they're even able to qualify. And so then it affects the financial hardships, the food supply, the financial well-being of their households, to where it really is not just a medical illness anymore. This is an entire society affecting problem. It's been very devastating across our nation. And I think as we're trying to rebuild that economy and, people are getting back to work, we still have the medical side that's going strong right along with it. So it really is a blended balance between medical health, mental health, and our social system, to truly get us through this. It's not as simple as the doctors will take care of the symptoms in patients. We all have to work on this together. We all have our piece in the world, which is why I'm happy to share my knowledge here. I understand the virology part of it better than, some of the folks that don't have my training. I'm happy to share that so we can together make collectively better decisions, whether that's how to open our schools, whether that's how to, manage our factories, our jobs, and our return to work with people that are affected or infected with this. I'm happy to share how we can, so that we can all together get through it and all be better, better society moving forward.
2 more points I want to make here, and I want to ask your input on that. One is extremely important for us to get into the concept of contact tracing. If you find somebody positive, just like we said, if the test is done today, the results don't come back for a week, you can't trace back to see who you're exposed to. So I think we are in need of close to 150,000 or more individuals who will specialize in this field of contact tracing. So the moment you find out that I'm positive, you find out the last 1 week or 4 days or 5 days, whatever it takes, to where I have been. Now, in some countries, by using the regular telephone and a little bit more technology, they can trace back within 10, 15 minutes where you've been. In us, it's almost impossible because we're not doing anything of that.
Yeah.
That's I think, a pretty important thing. Say a
Yeah.
few words about the contact tracing.
Yeah,
Why is it?
absolutely. And something I forgot to mention earlier that you asked me, as far as, and it's related to contact tracing, but as far as a kid that tests positive at a school, would one kid require the school to be shut down? It's really directly related to this question with contact tracing, because if one person gets it, the health department gets a notification of the case, and so the local health department, starts that task of contact tracing. And so the problem that we have here, like you said, a lot of it is not electronically driven. It's a very manual, labor-intensive process, to where there's phone calls, there's a lot of person or human work involved, and a lot of these local health departments are very understaffed. And so you're relying on maybe one or a half of an employee that's also dedicated to do many other tasks that has to trace all of these cases. So if they're trying to do contact tracings of, say, 30 or 50 new cases in a week, but they also have to run the vaccine clinic and see the chip program or whatever else their other health department duties, require of them. It's very limited amounts of time that requires a lot. So certainly I recommend, for our governmental figures and with our, people in the health departments, they need the help. If you can volunteer and spare time to help them, or allocate resources, they're struggling to survive with this. As far as the school side goes, if a single kid turns positive with a case, a contact tracing will start. And so it's not a matter of one kid is positive in a school, the whole school should get shut down. That decision will be made by the local health department authorities, and it truly depends on the spread of the disease in the community and the spread of the disease at the school. And so if one kid at the school is positive and their contact tracing suggests they're positive on a Monday and didn't go to school that day and were never at the school, there's no reason to believe that the school should be shut down unless they start seeing 4 cases now that are interrelated, same school, same bus, whatever, and they do contact tracings to suggest a common exposure point. If they can identify that, so if they have, several patients all at one time become positive and the contact tracing all points that they were in gym class together, now we have a very different scenario where they have to look at how do they segregate that from, contaminating a whole population of kids in a school. It might require, a couple of classes, a grade to be closed, maybe a grade school if it's one school, but not necessarily the whole district would have to get shut down or closed for that. Obviously, decontamination would have to take place if they thought in-school transmission happened, and they're prepared to do that. But just because one kid is positive does not single out and mean they became positive from an exposure at the school. And so we really have to rely on our health department folks to do that contact tracing and figure out, were they at a family gathering with an ill individual? Did mom come home from school or from their job with it first, and the kid got sick 4 days later and probably got it from an in-household contact? Those are all things that the contact tracings have to sort out before they say a kid's positive at a school, we need to close that school. Much more detail needs to be involved, a lot of discussion and investigative work before they get to that point.
Yeah, one other point I was reading that if we had invested 35 to 40 billion dollars a few years ago to prepare for what we're going through, and even now, if we invest that for the next pandemic, which will be somewhere in the next 5 years, 10 years, 20 years, then we would have saved ourselves from trillions of what we are losing in the world. So I think the whole world is in it together. We need to get the benefit from all the scientists of the world together and hopefully continue to follow your advice and everybody else's. So thanks, Dr. Wood, for everything you share. And you stay with me for a while because now we're going to do the radio show pretty soon. So I hope we can come back in the next couple of weeks or whenever they want us to come back. And we'll continue to share with everybody what you and I can learn and share with each other. So till then, we hope you all stay well and safe and take care of each other and follow the instructions and listen only to the scientists, not to the politicians as such. So till next time, Dr. Woods, thanks again. And thank the city of Weirton for making this possible for us to share this information with everybody. Thank you again. Thank you.
Thank you. Very happy to be here.
Thank you. Bye-bye.